I'd like to start by saying thank you very much for inviting me to be here with you today in Leuven. I came to SSBP conference in Leuven, so I was delighted to be invited back because it's a wonderful city, and really pleased to be able to talk about some of the work that Lauren was involved in. I only got to meet Lauren twice, but just from those two meetings, the passion and the commitment that she showed towards the TSC community was truly impressive, and she really left a lasting impression. I'm quite renowned for talking very fast, so I'll try to slow down. But I also know that you guys are waiting for lunch, so I know not to get between people at a conference and their lunchtime. So I will try to touch lightly on some points that have already been covered. So as Petra said, I'm going to be talking about the behavioural dysregulation cluster. And some other things. So we've seen this umbrella, we know this, we know the behaviours in TAND, and we know that these behaviours, at a very conservative estimate from a very heterogeneous sample, the Tosca sample, suggests that at least 36% of individuals show at least one of the behavioural difficulties at the behavioural level of TAND. And we know, as Petra said, these are behaviours which are the reasons that people then tend to get referred onward to services. And when they reach services, they may get a psychiatric diagnosis or they may get a label. And one of those labels is challenging behaviour. Whether we like that term or not, and some people don't, it's these challenging behaviours that really map onto some of these dysregulated behaviours that we talk about. So we've seen this little graph before, and we can see that in the behavioural dysregulation cluster, there is aggression, there are mood swings, and temper tantrums, and they really do ring a bell for people that work with challenging behaviour. But we also, in that bracket of challenging behaviour, often see self-injury described. Now, in cluster analysis, the self-injury maps onto the ASD cluster as well. I'm going to borrow back self-injury for a couple of reasons. One is that it is so often talked about in the clinical and research literature together with aggression, and also because I believe that they are likely to have a shared etiology, a shared cause in tuberous sclerosis complex and in other syndromes and people with intellectual disability and autism spectrum disorder. So these are the kind of headline rates of some of these behaviours, so mood swings and severe aggression at over 10%. And again, this is from the Tosca study, so this doesn't tell us a lot about what the behaviour or the characteristics of the people showing these behaviours are, and self-injury at around 6 to 8% as well. When we look at the studies kind of behind these headline rates, what we see is very variable rates of behaviour from the very low estimates on the left-hand side to the higher estimates on the right-hand side. And if we pull out these dysregulated behaviours, we can again see there are some really variable estimates. And these seem to depend, as you would imagine from what Petrus and other people have talked about some of the characteristics of the people showing those behaviours. So the characteristics of the sample. So children versus adults, people with intellectual disability compared to individuals without intellectual disability. And what this helps us to do is to think, well, okay, who is at most risk of showing these dysregulated behaviours? And these behaviours are really difficult for people to manage. When you think about the constellation of behavioural and health problems in TSC, if people are saying that aggression is a problem, sometimes more than the health problems are, we have to think that must be really difficult for the families if they're highlighting that as a really difficult issue for them. So, for example, if we choose the upper estimate of these behaviours, which comes from child-adolescent samples who have intellectual disability, we can see that around 2/3 of those people are showing aggression, temper outbursts, or self-injury. That's really quite a significant majority. So when we look at those kind of separated out, we can see that for self-injury, that seems to be really quite sensitive to gains in ability and also gains in age. So there is less self-injury in children and adolescents who don't have intellectual disability compared to children and adolescents who do have intellectual disability. And there's also less self-injury in adults who have intellectual disability compared to adults who don't have compared to children who do have an intellectual disability. So getting older and having less severe intellectual disability seems to reduce the prevalence of self-injury, but it's suggesting that children with intellectual disability should be identified as a really high-risk group for showing self-injurious behaviour. In aggression, the picture looks slightly different, actually. So children and adolescents, it seems to be more stable across the range of ability. So even children and adolescents who are really quite able often show aggressive behaviours. And it suggests that, we also see literature that suggests that aggression reduces into adulthood, which is quite reassuring for families if we can tell them, okay, this is difficult now, but it's likely it will get better, hopefully with some kind of intervention, while it is difficult, but into adulthood it may reduce. But it identifies again that childhood is a high risk time, most likely for all children with tuberous sclerosis complex. So just being aware that even the more able individuals with tuberous sclerosis complex may show aggressive behaviours. So I just want to describe the findings of a research study that we did looking at dysregulated behaviour, so self-injury, aggressive behaviour and property destruction. And looking at how persistent those behaviours are. So looking at behaviours at one time and then following up the same people 3 years later and just saying, do they still show the behaviour? And this was in what I would describe as a high-risk sample. So it's children and adolescents with and without intellectual disability, and then adults with intellectual disability. So there are no adults in this sample who don't have intellectual disability for methodological reasons, but because we don't have those in this sample, this is a high-risk sample of having these behaviours. And in a way, what's quite reassuring is that across those 3 years, actually around half to two-thirds don't show these behaviours. So these behaviours are completely absent across 3 years from half to two-thirds of the sample. But what's quite worrying is that when people do show these behaviours, they are highly persistent. So we can see that self-injury, if a person is showing the behaviour at time 1, 85% of those people are still showing the behaviour 3 years later. With aggression and property destruction, they still have quite high rates of persistence. They're identical, so 67% of individuals are still showing those behaviours 3 years later. So it's suggesting these aren't behaviours that we can just ignore and hope they're going to go away on their own. They do need some kind of intervention. So we've talked about the role of intellectual disability, we've alluded to the role of age, but there are some other person characteristics, which is what Petrus was talking about, that confer risk for showing these behavioural problems in people with tuberous sclerosis complex. So this is from the same study. Sorry to bombard you with graphs, particularly before lunch, but what they're showing you is, over here we have people who have persistent aggressive behaviours across 3 years. Over here we have people who never showed the behaviour, and in the middle we have people who showed it at one time point but not the other. Okay, and what we can see, and I want to draw your attention to the information along the bottom first, is that people who show persistent aggressive behaviour are significantly more overactive than those who show transient aggressive behaviour and those who show absent aggressive behaviour. So this suggests that being overactive and impulsive is likely to be a risk marker for showing aggressive behaviours. Interestingly, it's the same for self-injury. And then this here is about something that we call behavioural indicators of pain, and it's the same pattern. So people who show persistent aggressive behaviour have much higher or far more behavioural indicators of pain than those who only have transient aggression and those who have absent aggression. And those two groups are quite similar, which I think is quite interesting. And again, it's mirrored over here for self-injurious behaviour. Where these two differ is in terms of the role of repetitive behaviour in aggression. So that's showing here. And again, we see that persistent aggression differs from absent in terms of how repetitive people are. And this is unsurprising because this is about self-help skills, so how able people are, and that's just replicating the finding that people who are less able, so this group here, who are less able, are more likely to have persistent self-injurious behaviour. So these suggest there are specific risk markers that we can look at to identify who are the people at most risk of developing these behaviours, and those risk markers include being very overactive and impulsive and showing high rates of behavioural indicators of pain. So these are the groups that we should really look out for. I've not said very much about temper outbursts, quite frankly, because I don't think we know very much about what some of the temper outbursts are. I think they are poorly described in the literature. The most information we have is about prevalence, and they come from often tick box studies where people say, yes, my child shows a temper outburst, but we don't really know what they look like. We don't know the phenomenology of these behaviours. Sometimes we get descriptions like explosive rage outbursts, but what we don't know is what are the people doing when they're having these temper outbursts, and to what extent do they overlap with some of these other behaviours that are described really quite well in tuberous sclerosis complex. And I think this is something that we need to look into in more detail, and a PhD student at the University of Birmingham, Stacey Bissell, has been doing interviews with parents to try and elicit descriptions of what these temper outbursts are, which might give us an idea about what to do about them. But I think we also need to think about, in terms of when we're saying are these temper outbursts a problem, are these developmentally appropriate behaviours, or should we say they're clinically significant based on how often they happen, how severe they are, and at what age they're happening? So, for example, we might say that temper outbursts into adulthood are clinically significant behaviours because they are not developmentally appropriate. We don't know what the mechanisms underlying temper outbursts are, so do they fit well within an operant framework? Do they serve a communicative function? Are there difficulties with inhibition? And that maps onto what Petros was talking about with the neuropsychological difficulties, or broader problems with emotional dysregulation, so difficulties controlling emotional responses. And that maps on nicely. So mood swings have fallen within this behavioural dysregulation cluster, which intuitively makes sense. But again, when people are ticking something to say there are mood swings, we don't know necessarily what they're saying. Is it just a synonym for temper outbursts? Are they just saying that it's a propensity to having temper outbursts? Or actually, is there a more generalised issue with emotional lability such that people can be very high and very low? And I think that'd be something that's really interesting to hear from clinicians' experiences of asking people with TSC and their caregivers what those experiences are. Because I'm not sure that it's currently very well represented in the research literature at least. When we group all of these behaviours together, so when we group temper outbursts, self-injury and aggression together, these are really quite often understood within an operant framework. So this is suggesting that these behaviours have some kind of social communicative function. They are doing something for the person who's showing them, and that they may be reinforced by environmental responses. So I'm not sure how familiar people are with the idea of the operant framework, but very briefly it's the idea that somebody needs something or wants something, and if they show a problem behaviour, that's difficult for the people in their environment to manage. So what they do is they understandably try to do something, so they engage with the person. The person then finds that rewarding, which increases the chance of the behaviour happening again, so that next time they want that thing, that behaviour is more likely to happen again. All of that sounds like that's very deliberate. It isn't. In no way are we implying that the person showing the behaviour is meaning to elicit that response, or that the person responding to that behaviour is meaning to reinforce the response. It's just commonly what happens. And there's positive reinforcement where somebody wants something to be given, or negative reinforcement when there is a need for something to be stopped. And that's really quite common. So somebody doing an aversive task may show difficult behaviour, and then that task is taken away because the difficult behaviour is very hard for the people in the environment. But what that means is next time they want the task to be taken away, they may show that behaviour, and then we get into a really difficult intransient cycle. And so if we can understand this kind of reinforcement cycle, it suggests areas that we could potentially intervene. And it's quite a complicated cycle, so I'm really happy to chat to anybody who's not familiar with it, who wants to talk about it some more over lunch. But what it does suggest is that if we can optimise people's communication strategies so that when they are wanting something or when they are finding something aversive, then perhaps it would be easier for them to communicate that in a different, more adaptive way rather than via difficult behaviours. It also suggests that people around the person should be aware of their own responses. It's very hard not to respond immediately if somebody is banging their head or they have punched their brother or sister. But actually, it's important to think, okay, what am I doing in this situation? And people need support to do that. There's a whole lot of literature now around positive behaviour support, which uses these principles around function and understanding function to address these difficult behaviours. So if anybody wants to know more about this, I'd really suggest looking towards this positive behaviour support literature. I think it also may talk slightly to why anxiety in some of Lauren's analyses has loaded into this cluster, because when somebody is very anxious, it may exacerbate this need for something to happen or for something to go away. So if we think about phobias, if somebody is very anxious about a particular stimulus, they are going to want that to go away very quickly. If they can't say that they want it to go away, then they have to use the behaviours that they can access easily. So these are the associations that we've talked about before with overactivity and impulsivity, and this is quite theoretical, but it's just important to think about what the role generally of dysregulated behaviour might be, difficulties with what we call behavioural inhibition, and that just means either stopping a behaviour before it started, or once it started, putting the brakes on it, being able to stop a behaviour once it's up and going, and that can be quite hard. And this has been modelled. This is quite small. Sorry, I'm hoping I can make the slides available so people can see it a little larger. But it just suggests that severity of difficult behaviours over time can increase, and one big driver of that increase is impaired behavioural control. But it also includes in this model intellectual disability and ASD impairments contributing towards the trajectory. And I think that really speaks to tuberous sclerosis complex because of these additional constellation of behaviours. And the original model was specifically for self-injury, but I think the middle section, which talks about environmental control via social reinforcement, is really likely to be applicable to aggression and to temper outbursts as well. One thing I want to talk about, and this is, you'll probably be pleased to know where I'd like to end really in some ways, is that within this model, they've included painful health conditions. And people have already talked and are so reassured to hear people talking about the link between pain, illness, and behaviour, because in the wider ID literature it's really not very widely acknowledged, but pain can often act as what's described as a setting event in the operant framework, and what that means is it changes the relationship between a situation and a behavioural outcome. And I think the most intuitive example of this is if we have a headache and we're driving, we are far more likely to beep our horn at people who drive into us around a roundabout or something along those lines. We just become much more irritable if we're in pain, if we're hungry, if we're tired. These are all setting events. And so it's important to think about these painful health conditions. We see it mirrored in the research findings. So people with persistent aggression and persistent self-injury have higher levels of behavioural indicators of pain than people who don't have persistent self-injury or aggression. And that's really problematic in TSC because of the range of health problems that we find in this syndrome. And this is a paper that just simply listed the types of health problems that there were, and I've highlighted the health problems that are likely to be painful: teeth problems, bowel problems, gastric problems. I've highlighted epilepsy and seizures because of the likelihood of brain tumours and so on, and also skin problems. And what we do know with pain and illness is that the gold standard of identifying this is that people tell us. They describe what it feels like, they describe where it is, and we know that in tuberous sclerosis complex, a lot of individuals will have communication problems. And I'm not just talking about the group of people who have profound intellectual disability, it's also people who have who are more able but still struggle because of social communication difficulties to describe and label quite abstract things like pain. So these communication difficulties can preclude effective self-report, and therefore the behavioural signs that people have talked about may either be missed, completely missed, or misattributed because they overlap with mood. When we describe how people appear when they're ill, we say they're miserable, they're tired, they seem tense, they're restless. And those are quite nebulous, they're quite hard to pin down what they are. So it's really important for people to be aware of changes in this cluster of challenging behaviours or dysregulated behaviours, inactivity levels, eating or sleeping, or reduced interest or avoidance of activities. And to do that, it's really important to monitor behaviours. And there are tools available to use for people who are non-verbal. So this is the FLAC pain scale, which looks at people's facial expressions, their activity levels, whether they're crying and so on, and caregivers just rate what their behaviours are. There's the non-communicating children's pain checklist by Brew and colleagues. But what I think is really important, I think this is what Petrus was saying, is that if somebody is showing really difficult behaviours, it's very important, I think, to first of all rule out that they are experiencing a physical health problem that's contributing towards them showing these behaviours. It's a much more effective way of reducing the behaviour, but also nobody should be in pain without it being identified, and it can have serious health consequences in TSC specifically. So before I finish, I bought my phone not because I want to read Twitter or anything as I'm presenting, but I think this reinforces the case study that Petrus was describing, actually. So this is a quote from a caregiver who took part in a research study and received feedback from the non-communicating children's pain checklist. And this child's scores were really quite high. So the parent said, her individual results came back to us having been analysed, and several times in this report it recommended that we check her out with her GP because she was showing behavioural signs of being in pain. We thought these behaviours were part of her TS and challenging behaviours in general. In fact, during discussion, her renal consultant decided to push for an MRI, as her paediatrician locally hadn't felt it was necessary to arrange one at all. Claire was then found to have a SIGA, which was removed by emergency surgery 2 weeks later. So indeed, her behaviours were an expression of pain that no one knew about because of her communication difficulties. And I think that's really quite compelling evidence that, you know, we really need to be thinking about pain when we see difficult behaviours and changes in some of the other behaviours that people will be talking about today. So that's where I want to leave it. Thank you all very much for listening. Thank you to the families who take part in all of our research, and also to my colleagues as well in the Cerebra Centre. Thanks very much.